getting better, getting worse. It will also help you with your medication. Is the medication working? I don't know. I didn't document the first time how big it was. Documenting erythema, how big the redness is huge in your cellulitic, a patient that has cellulitis or infection in their skin. Huge. You've probably seen this. People go to the ER, they'll take a surgical, Travis is shaking his head, they'll take a marker and they'll draw a border around it. Because if it's really big, you're probably like, how do you document something that big? There is a time when you're like, my God, that's 52 centimeters. But yeah, you can draw a border at it because they want, when you come back, they want to see if it's outside that border. Get it? I know you do. So I've cut out a huge chunk of this. This is one of the lectures that I'm going to give you. If you want to look at it, I highly suggest, again, not for testing, I will not write a test. I will not write a test question out of it. But it will help you in all of your lectures. It's big, it's like 80 slides, but it's basically an introduction to morphology. This is the condensed version of it right here. Because when you go through these lectures, you're going to hear the whole papule, you're going to hear all that stuff, and you're going to be like, I have no idea what that means. And again, there are certain measurements. So a papule is 3 centimeters, as where a macule is 3 centimeters and up. Because you have to determine how to document or code for what it is. Papule, macule, wheal, urticaria, what is it? Does that make sense? I know it probably right now does not. Because you're like, well, we've never even seen this stuff yet. This is a condensed version of it. I'll give you the lecture for you to review. I'm just looking here. Because essentially when you lay eyes on whatever you're looking at, because let's say you had just a rash. We all know what a rash is, right? Like, let's say I had a rash right here on my forearm. How would you describe that? Besides saying erythematous and saying the measurements, how do you describe the characteristics of that rash? Does anybody know? Say that.
Doesn't it just depend on the rash, what it looks like?
Well, it's going to be in regard to this right here. This is how you describe it. You say macular rash located on right forearm, or maculopapular rash, or depressed. This is the terminology you're going to utilize. And again, I'm sorry, I know right now you're probably like, I don't like this. Just, it's going to come, I promise. It has to be introduced to you somewhere. So that's morphology. That's the terms you're going to utilize to describe things that you see. Then, adding on to it, you have to describe the shape. You have to describe the arrangement, and you have to describe the distribution of the dermatological finding. And here are some examples. And these are the words you have to use. You do get you have med-term for this course? You'll get a med-term? Okay. So some of this stuff will be totally, in actuality, that's where we actually got it, was in our med-term, the whole papule wheel. Have you looked at your stuff yet? Do you have it available to you? That may be in there, actually, in regard to what a papule is, like what the measurement of it is, what it means to be classified as a papule. So these are just some examples of what's in the previous slide. So this would be considered annular. This is a ringworm, I think. It's not written there. That's what a ringworm looks like. So you would say, patient has a 3 centimeter by 4 centimeter erythematous annular lesion located on the right forearm. Borders are raised with scaling, central clearing noted. Several areas of excoriation located around the outer border of the annular ring. No exudate or drainage noted, period. That's how you would describe that. This would be an example of how to describe exudate or scaling. Patient has 2 erythematous lesions located on the left forearm, one measuring 2x3, the other measuring 5x4. Soft to touch, increased warmth, no central clearing, no raised border. Confluent yellow exudate noted across lesion. That's how you would describe that. This is an example of polycyclic lesions. This is arcuate. Because again, when you go to see some of these things, you're going to be like, how in the crud do I say this in words? You'll struggle with it. This is a linear distribution. Don't worry about what the condition is, just understand how you would start training your brain to look at this and put the words that you see on paper. Bless you. You'll see this a lot. Reticular or lacy-like pattern. We often see this in newborns. It's called levator reticularis. It's totally benign. But you can also see this skin pattern in individuals that are going into sepsis or in sepsis shock. They'll have a reticular. Why it stops just where that black's drawn, that would normally be all over their body. But it is extremely indicative of skin changes for people that are in septic shock. Ceropiginous. Targetoid or bullseye, that's another way you'll hear this described, and you can see why. You have red ring, white border, red ring, white border, get it? It's like a bullseye target. Marbled. So those are just some of the shapes that you can see with skin findings. Now we're going to look at, you have to do, first and foremost, where is it located, right? Arm, leg, head, left, right. Where's this location first? I always start with that. The next thing I do is I'll say, just really briefly, just a general shape of it. Annular, linear, whatever I can come up with. Most things you're going to see are annular. I always say the color at that point, which 9 times out of 10 is going to be erythematous. So I'll say erythematous annular, erythematous papules, erythematous maculopapular, comma. Then I'll say it's grouping or arrangement. Is it grouped? Is it single? And then the last thing I comment is on distribution. And again, there's no rhyme or reason where you stick it. You can do it in any order you want to do it. Just try to touch on those biggies. The shape, the arrangement, the distribution. Give me a color of it. If you need to measure it, measure it. If you need to touch it, tell me about the touch. Increased warmth. Induration. Have you ever heard the word induration and fluctuant? Indurated means hard. So you're going to get abscesses a lot. Tons, and I'm giving you a lecture over abscesses or bacterial skin infections. Indurated means you go up to feel of it and it's as hard as this desk. Versus just normal skin that you can push into that's spongy. So when you feel that, you're going to note 5 centimeters by 7 centimeters indurated area, meaning it's hard as a rock. I'm not going to put a blade in it because there's nothing I could drain from you. it's extremely important to document indurated versus fluctuant, because fluctuant means, if you had to think about it, it's like touching a water balloon. Or if you took a balloon and filled it with yogurt, something with a consistency, put your finger in the middle of it, that's what fluctuant means. So you'll say 5x3 indurated area with a 2x1 fluctuant center. That means I'm going to put a blade in that fluctuant area because I know there's something in it and I can drain it. And you'll get that in my bacterial skin lecture. So arrangement. Is it grouped? Is it scattered? That's grouped. That's scattered. If you ever have a rash that's just got everywhere, you can say diffuse. Because again, how do you say if something's, you need to say where it's located. Rashes on the arms, legs, abdomen, torso, face, wherever. But you can say diffuse rash everywhere. Yeah, I'm not going to give you a bathroom break. If you want to go to the bathroom, you totally can, only because of the computer thing. So if you want to go, you can go, but I'm not going to give you a break. But it's okay if you want to go. Also, if you have numerous lesions, and I've ran into this before, you don't want to measure all of them because you're like, God dang, this is going to take me 6 hours to measure all these things. I'll measure the smallest and I'll measure the largest. And I'll say ranges in size from smallest 3 centimeters to largest 10 centimeters. Because again, you'll have people that come in and you're like, I don't have time to. So distribution, dermatomal. That was really indicative of your folks that come in with shingles. They'll come in with shingles, and it will be in a dermatomal pattern, meaning it's following the skin dermatome. I'm not going to lie to you, number 2, I've never documented that word. But you do need to be introduced to it. The third one, I think we've kind of somewhat spoke about this before. You can have skin changes that go along the line of the lymph nodes. Cellulitis can do it. And that's why, and again, I'll say this in my lecture, the bacterial skin disease lecture. Anytime you document someone that has an abscess, you always want to comment if they have red streaking or not. No red streaking noted. And it's extremely important to document that in there. Because if they have red streaking coming from the side of an abscess, that means it's infected their lymphatic system. And that is not good. You cannot just let them walk out after an IND with a prescription of Keflex. So anytime I have an abscess, I'll always comment on streaking. Sun exposed, sun protected. Acral is an odd one. It just basically means hand, feet, wrist, ankles. You'll see that word, acral distribution or acral location. Instead of, and again, this is just saving you time when you document. If you don't want to document hands and feet and wrists, you can say rashes located in acral regions. That's a quick way of knowing, I know exactly where that's at. Extensor and flexor. I know you were introduced to that in your musculoskeletal, hopefully in regard to what your flexor surface is versus your extensor surface. Does everybody understand that? Because it's important in your derm section in regard to location. And there are 2 main skin conditions that you follow rules in regard to where they're located. Psoriasis and eczema. Extensor, so knees, elbows, is psoriasis. Eczema is usually in the flexor. And if you've ever seen a kiddo with eczema, you know it to be true. Their eczema is located right here you'll see them let them scratch it, and then their eczema is always located right here. So again, if you understand that and you document, it helps build your case for eczema. Rash located in flexor, antecubital, popliteal. You can even break it down further and say where the flexor surface is, and you would need to. You would need to say antecubital, popliteal. I know you understand these words. Is it localized? Is it generalized? If it's symmetric, you do need a comment on that. Here's just a little picture of some of the main locations for certain types of dermatological findings. I know you haven't had these conditions yet, so don't spend a lot of time on this. It'll make more sense when you get those medical conditions. Any questions thus far? This is the final stretch here. Actually, some pictures. So skin. This is taken from your sheet, your FSDA sheet. You're going to inspect and you're going to palpate. Palpate or touch. Palpate, I always think of like kneading or whatever, touching it. You're going to note the color. You're going to note the presence or absence of moisture. You're going to note the temperature, texture, and lesions. So color of skin, that can run the gamut. Obviously, there are many different ways you can determine or describe color. It's pretty straightforward. I'm just looking here. Brown, and again, everybody has their own little skin tone that is for them. That's who they are, so be mindful of that. But there are obviously pathognomonic color changes. Brown is caused by darkening of melanin pigment. There are many different conditions that you can see. And again, that's not what this lecture is about, but to introduce you into some of the ways that color can look at, if it's bad, what it looks like. So if it's generalized, we introduce you to your adrenal gland issues, like Addison's disease. If they have a overall darkening or tanning of their skin, so that would be the adrenal disease, versus localized browning. So a nevi or a mole. Neurofibromatosis, which is what that picture is, that is an example of localized areas of brown skin. White, opposite of what we just said. Absence of melanin. There are many different dermatological conditions that you can have white skin changes or white coloring to the skin. And again, it's all about comparing it to the other area. So if you have if you have an area that you're concerned about and you're like, I don't know if this is your skin, just compare it to the opposite. That's the best way to do it. That's why anytime I ever have anybody come in with a lower extremity complaint, I make them uncover both of their legs, because I'm going to compare it to the other one. So this would be an example of white or decreased melanin. Vitiligo is actually an example of that. So if you wanted to describe the hand, the back of her hand, of course you'd say location, right or left, location of the hand, volar, dorsal or posterior anterior, however you want to do it. You can say volar, however you want to describe the back or the front of the hand. However, there's many different ways you can do it. You could measure that, or you could just say generalized loss of pigmentation. Or you could say 10 centimeter by 10 centimeter white macule, or 10 centimeter by 10 centimeter white patch. There's different ways you could do it. And if you wanted, obviously right now you're doing mainly an inspection, you're just visualist, but you could, obviously use your fingers or your hands to touch this if you wanted to feel the texture of it. Red, this is the main one you're gonna see a lot, especially in your family med, ER, urgent care. It's caused by increased blood flow, so we see this in infections, inflammation, vascular changes. Those are the big time, that we see in an erythematous change to the skin. So this is an example of urticaria. And again, to describe that, you would just say diffuse urticarial lesions located on patient's chest, abdomen, neck, however you want to describe it, the location of it, wherever it was. This is something that I would lay hands on. I would palpate and touch that. Because I want to see, is it rough? Does it blanch? Hives and urticaria, it's huge to see if it blanches or not. Hives, urticaria blanch, meaning if you put your finger into it and then remove it, for just a split second it stays white and then the red comes to it. That's indicative of hives and urticaria. So I would touch them. This is where I would put my hands on it. Yellow, the three examples that are given here are generalized. I don't think I've ever seen an instance where I have localized yellow skin. I can't think of anything. Most of the times that I've dealt with patients with yellow skin, it's been a full body yellow, and it's mainly because they have horrible jaundice, secondary to liver disease. So that's an example of jaundice. And again, in your physical exam component of your document in your skin section, you wouldn't say patient appears jaundice. You would say patient's skin is diffusely yellow. Because you can't technically say a diagnosis in your physical exam. Blue. Scary. This is cyanosis. You can have blueness. I've never seen someone diffusely blue. It is usually localized. Lips, nose, fingertips is where you'll see cyanosis. There are different reasons people can be cyanotic, but usually it's decreased oxygen, right? They are not getting enough oxygen. You'll see it in your kiddos that are having a major asthma exacerbation. Well, they're about to crash if they have blue lips and blue nose. So be very mindful of that in your asthmatic kids if they come in with blue lips, blue nose. Their oxygen's tanking. You can barely see it, but you see that blue hue to the tip of her nose and her lips. Forget the fact that her hands look like alien hands, but I use this picture actually in the later slide. The tips of their fingers are blue. You can see it under her nail beds. Skin moisture, so is it wet? Is it dry? Some of y'all's faces are like. For the most part, you have normal oil concentration on your skin. It's there to protect it. And some people are just more, have more oily appearance than others. There's nothing wrong with that. It's when it is going to a pathologic level. And usually, the biggest thing that I've dealt in my practice is, again, moisture with diabetics in their feet, or moisture with women that are overweight, and it's in between the breast and the pannus and the growing folds. This would be a good example. You wouldn't have to touch this with your bare hands. You could use a glove for this and notice that it's moistury, that it's wet, and it should not be. So this is an excellent representation of candidiasis, or a yeast skin infection. You're going to see this a lot in family medicine. And again, especially with your diabetics and your overweight patients. And you would just note that it was moisture present. Temperature, I mean, this is pretty straightforward. This is now, you know, you're going to touch, you have to, this would be an example of where I would not want to wear gloves. Because if I really wanted to determine if it really was increased, it was hot, I would need to touch that with my hands. That's just me. And what I do, if you're ever sitting there going, I freaking, just put your hand in the same area on the other area of their body to compare. It's that simple. So if you have a lower extremity that has a big old cellular or an abscess, and you're like, I want to see if it's hot, just place it there and touch the other area. And you can, in 2 seconds, tell if there's a skin difference. Temperature-wise, I'm sorry. And again, this just goes along with variations. Everybody's different regarding their skin. Don't ever freak out if you touch someone's skin and it's cool. If it's diffusely cool and it's the same on both sides, you're good. If one extremity is cool to touch and the other one's warm, that is when you become concerned. You have to compare it to the other side to help you hone in on what you're dealing with. And that's all that saying is. You need to know. And the easiest way to do that is you can document 1,000 ways. Warm to touch, increased warmth of the right lower leg versus left. Cool to touch, you can say it any way. This is really important in your cellulitic or infectious skin stuff, hot heat. Because infection loves, it amps it up so the skin will be hot compared to the other. Not an excellent picture, but you can kind of see in the areas where he has decreased blood flow secondary, the tips of his digits are white or pale, you can kind of see that there. If you were to palpate those or feel those, they would be cool or decreased temperature to the other part of the hand that was pink. And you would document that. Cool to touch in areas of decreased blood flow. That's the way I would document that. And I'd be specific on what digits and what location. A really good way to help you with documentation anatomically, if need be, is just think about your anatomy. Like, is it the DIP over the skin overlying? That's a big one I say all the time. The skin overlying the DIP joint, the skin overlying the top of the right foot. You could say it like that. Think of what is underneath the skin to help you determine how to best describe it. This is an example of cellulitis, or basically skin infection. So if you were to place your hand there, it'd be hot, or definitely increased warmth. Has anybody ever had a skin infection or seen it where you touched it and could tell the difference in any kind of work or personal? It's crazy how big of a difference it really is. It's weird. You're like, wow, that is hot compared to your leg, other leg. It's weird. So texture, it's a component that you want to, obviously you can visualize that and look at it and tell that it would be rough. But you would say, upon palpation of patient's heel, rough texture noted. And essentially your normal, because all of these have to have a normal to have an abnormal, right, to document. It should normally be smooth. You know that. You know your own body and what should be smooth versus what should be rough. A good example of texture would be for, again, I would go back to the rash that you get with scarlet fever. It has a very odd, it's pathognomonic. If you ever hear the word sandpaper rash, you can stop reading the question and go down and choose scarlet fever. It has a sandpaper feel to it, and it does. It's odd. You know what sandpaper feels like if you've ever felt sandpaper? You can take your hand and rub it over the patient's, because they normally get it on their torso. That's where the rash is, and on their face. You can take your hand and rub it over it, and it feels like sandpaper. It is the weirdest thing. And I would literally document, rash is a maculopapular located blah, 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 erythematous sandpaper-like texture. That's the best way. Somebody read that and be like, oh, I know exactly I know what that means. Does that make sense? Again, it's just all about doing the physical exam, making sure you're doing the right stuff, even though skin's pretty easy. You either look at it or you touch it. But half the battle, this is where I love medicine, is taking what you find and putting it on a document in a coherent, intelligent manner. That is the biggest downfall I see in providers, and the things that I was never taught as a PA student, was how to properly document this stuff. It's embarrassing. You'll see it, you'll pick up people's charts and you'll be like, that is sad. Don't be that person. Be better than them. Skin turgor, I taught, throw this in here. Again, skin turgor, pretty straightforward. Again, you just, and this is legit, Rob and I were actually talking about this last night, because again, I know, you get stuff in physical exam or phys doc class, and you're like, I am never going to do this. This is insane. Which is really actually not true. I know when people go out and do specialized stuff, they're like, that's stupid, nobody does that. Well, probably not, but you do need to know how to do this stuff. So I asked him last night, I said, do you really check skin turgor on people? And he's like, absolutely. He said, I don't do it in kids. He said, because most kids, if they're that deep, kids are little plumpy things, right? You ever seen a little 6-month-old hand? It looks like a water balloon. It's just puffed up. Which is why, actually, in a pediatric patient, to check their skin turgor, you do it on their glabella. And I had to educate him on that. I said, well, actually, it's not their hand. You need to do it right here. You can actually pick up their glabella right here and let it go, and if it stays tinted, that is a sign of dehydration in a kiddo. But in an adult, because kids are chunked up, you do it on the back of their hand. See, mine just hangs up there because I'm so dehydrated all the time. See how mine just hangs up there? Seriously, I'm poorly dehydrated. And how you document that is, you can say skin turgor increased. I've seen it a million ways to document it. You can even actually say how long the skin hangs up there before it goes back flat. 2-second delay, 3-second delay, skin tinting noted. There's a lot of different ways you can do that. Rob said he absolutely documents that, especially in conjunction with, and this is true, mucous membranes. So what would you see in a mucus, because it's kind of derm, if you were to, what would be indicative in mucous membranes for fluid status? Mainly dehydration. Say that?
Dry.
Dry, so how do you document that? Does anybody know how to document dry mucous, you can say dry mucous membranes if you want, but that's kind of silly. Dry, really? Is it dry?
Yeah.
It's tacky. That's exactly right. Very good job. You say tacky membranes noted. So, again, it's all about, I don't want to tell you to document defensively, but it's documenting defensively. So if you had a person who was dehydrated, you want to really show that in your note, to look like a rock star, you would say, fluid status assessed versus with vitals, patient is hypotensive tachycardic, and I'd put out their numbers. I'd say also skin turgor, 3-second delay with skin tinting, patient's mucous membranes are tacky. That's a great case for dehydration. And in their ICD, and I would put dehydrated, in their plan of care, I'd say 1 liter bolus with maintenance fluids over the next 24 hours, whatever. What's another thing you can do for dehydration? A third component. It was up in the very top of your slide. It may be coming up. Cap refill, absolutely. There's a lot of people that will poo-poo on cap refill, but you can use it. I mean, you can. Skin lesions, we've already went over this stuff. I've told you about how to describe it. These are some of the main characteristics you're going to want to note in your document regarding skin lesions. You're going to want to measure the size, the shape, the color, the texture. Is it elevated, depressed, pedunculated? Bullet point 6, that's your morphology lecture. That's your morphology stuff. This is an example of a pedunculated lesion. Pedunculated means on a stalk, hanging off. I know it's kind of gross. Skin exudates. You'll hear that word exudate, and you're like, what does that mean? It just means goop, ooze, drainage. You can actually describe exudate. Bloody, serous, serosanguous, foul odor, green, purulent. We love purulent drainage. Crusting, honey crusted. That's a big one. That's for impetigo. Honey crusted exudate noted. Honey crusted, it literally looks like you took honey, you dried it on their skin, you go to pull it off. That's honey crusted exudate. Hair's pretty straightforward. You can only really talk about its texture and if it's there or if it's not there, right? Is it enough or is it decreased quantity? So quantity meaning, is it thinning or is it appropriate? Distribution, you can talk about that in many different ways. Is there hair loss? Is it diffuse hair loss? Is it pattern, meaning patch missing, patch missing, patch missing? There's different ways you can describe hair loss. When you get those lectures, the biggest one I can think of is kiddos getting ringworms in their hair, or alopecia. This will, you'll put the two together, hopefully. Observe for broken hair shafts, chemical or mechanical, meaning is their hair broken off? If it's smooth, bald, that's something different. But if you can see their hair shaft where it's been broken off, that leads you that there was some type of trauma, that's the braiding of too tight hair and it's broken off. That helps you determine potentially what the pathology is. Of course, nits or parasites, that's your last lecture that you're going to get. And as a provider, you're going to have the beauty of, having to do that. You need to do that. You need to go into the person's hair and actually identify if there are nits. That's the, you have the eggs when you have lice. There are eggs attached to the shaft, and then you will also see the alive lice moving around. You have to know that type of stuff. You don't have to give me the number of lice or whatever. You just say live parasites noted, nits attached firmly to hair shaft. And you'll see it if you've ever already seen it. You'll take a hair strand and there'll be an egg attached to it. You can take it and you can slide the egg off. This is attached to the hair shaft. Texture. Most hair should be soft, not brittle. You can actually palpate hair or touch hair and tell if it's dry. There are certain conditions, this is important, one being hypothyroidism. They get that dry, brittle, if you've ever seen it. You go to touch it, you can almost feel like it could just crumble in your hands, almost like straw. So you will need to know their texture if they come in with a hair complaint. Nails, color, shape, if they have a lesion on the nail. Mainly you're going to be looking at their shape and color. There's many different variations in color of nails. The biggest one that I've dealt in is people who have fungal infections on their toenails, and that's what's going on in that picture. So you could say thick, some cracking with yellow-green colorization of the toenail. just say the color, yellow, green, green, whatever it may be. If it was a hemorrhage underneath the nail, talk about the hemorrhage that's under, you know, you get a subungual hemorrhage. Brooks has one right now, tell her to show it to you. I try to get her to drill a hole in it, she's like, no! You could talk about the hemorrhage underneath the nail. Which nail is it? Which digit is it? Does anybody understand the numbering of digits? How that works? 1, 2, 3. Okay, good. You can say the number, you can say when it's feet, you can say great toe. There's nothing wrong with that. But remember what is 1 and 2 and 3. Just remember that. So color, you can talk about their color. These are examples of what a splinter hemorrhage looks like. It is actually very common. You've probably had one at some point in your life. It can mean other things. Trauma is the biggest one. And again, you would just comment location. Pseudomonas, you'll have people that will come in with fungus, toenail fungus. If it has a green, dark green, black color to it, it's Pseudomonas. And you'll get a toenail fungus lecture. So don't get caught up in the details of the, I'm just trying to help you the physical exam, looking at it. Injury is the one there on the far right. That is, I smashed it with a hammer and now I'm bleeding profusely underneath my fingernail. If you ever have that happen, just go take a needle and heat it up under a cigarette lighter and take it, just drill it into your nail and it will just pop it right out and you'll never have that black, you know, you have to have it grow off, but you can actually get rid of it really quickly if you just drill a hole in your finger. Have you ever done that before?
I have.
It works. So again, you would just comment on the color of it. I mean, this is not rocket science. This is not a lot of fun descriptions here. What is the color of it? You could absolutely touch that also. It's rough. You know, most nails should be smooth. If you feel ridges, if you feel roughness, if the texture is flaky, you can comment on that in your document. So visualization there. Bless you. Toenails are important. Oddly enough, there are a lot of systemic illnesses which have very odd fingernail findings. Psoriasis is a main one, big one, that people often know is pathognomonic. People with, anybody in here know, oh man, it's a bad skin thing to have. Anybody know anybody with real psoriasis? It is very, are they diffuse, is it bad? Oh man. I feel so bad people with, you know, eczema for the most part, people will grow out of eczema, for the most part. Psoriasis is one that's going to be with them, and it can get out of control and cause a lot of embarrassment emotionally for the person. Psoriasis, oddly enough, can have nail findings that are odd, and that's a picture of it. They will get like a pitting, a divoting, a chunk look out of their fingernails. And you can feel that when you palpate it or touch it. White spots, lots of people have those. It also, and this is not listed here, but don't look at your nails and think, oh my God, it's me. It can also be a sign of certain nutritional deficiencies. There are certain vitamins that can be low, vitamin D being one of them, and you can get those little white spots in your nails. And to be honest with you, in regard to the nails, unless they come in with like a raging toenail fungus, oh my gosh, you don't normally look at people's nails. I mean, you know what I mean? Like that's the biggest complaint. People, they're not going to come in and say, I have 3 little white dots on my finger. What I'm trying to convey here is, if there are certain disease states that you know of that you think is going on with this person, you can go to their nails and look, and it can help with your case a little bit. I'm just trying to throw out there what weird things can be in the nails that you can document. You would also comment on if the nail bed is not attached, so if the fingernail is lifting. This one's actually starting to, not a great picture, but you can kind of see the nail bed is lifted. Nail shape, I don't even think this guy has any nails. I'm like, what is that? Here are just some odd things in regard to the nail plate shape. Bow lines, it's this odd line that you can get across the fingernail. Nothing systemically ill, it's just repeated trauma to the nail. But if you were just doing a physical exam on somebody and looked down and saw that on somebody's thumb, you could just say, what happened to your thumb? They could say, oh, about 6 months ago I hit it with the hammer. You'd be like, okay, cool. But I would actually still document it. I would say bow line or longitudinal line located on thumb, right thumb. It was just an incidental finding. Angle is important. We've talked about clubbing before in your other courses. You'll note clubbing when you see it. That's clubbing. It's an alien, I feel bad. It's like an alien, I don't mean to be rude, but like an alien hand. But you can tell, have you ever seen anybody with clubbing? People with cystic fibrosis, people have certain genetic, it is odd. It's like literally like a ray. It looks just like that. That is clubbing at its finest. You can have issues with your proximal and lateral nail folds, so lateral and proximal. That would be indicative of an ingrown toenail, and you would just comment. Proximal nail fold, erythematous, fluctuant to touch, increased warmth, sun purulent drainage noted, period. Nail palpation, you can read it, I've said some of this to you. And there's no rhyme or reason to it. You just take your fingers and you touch it, however you want to do that. And I haven't mentioned this, I should have. Anytime you touch, you always want to document pain. Is it painful when I touch it? That's not good. It should not be painful when I touch you. Fungal infection, plate is lifted up off the nail, you can see it. Spoon nails, the biggest time, and I've actually seen this on an inpatient, patient that was inpatient for horrible anemia. You get this with anemia. People who have certain types of iron deficiency anemia is a big one. We already talked about bow lines. Any questions? I will email, or I'll post them on D2L and email you as well if you're a D2L hater like me. I'll email you the morphology lecture. I'll email you the examples of a normal skin. If you looked at me and my skin was normal, how would you document a normal? Because that's sometimes hard. And then I will also email you kind of a generalized how you do a comprehensive skin exam. And that's no test questions, just something for you to utilize this course. If you have any questions about anything, please come and find me, call me, email me, anything. Okay? You guys did great. You guys have a good rest of the day.